Dr. Mulholland back with you in Charlotte, North Carolina. We have seen section 1 of our injection suture suspension facelift. We've injected RF internally with Accutite FaceTite, externally with the Morpheus. I showed the Morpheus body, the M24, the prime, and the resurfacing. We've injected RF skin tightening, reduced the fat, got FSN, contraction and dermal remodeling. Now we add volume, section 2, part 2, heat, then filler. And we look at our young lady here. We're going to zoom in and look at her supraorbital temporal buttress. Temporal hollow looks good, doesn't need anything. If it's too concave, you want to volumize it, but she doesn't need that. I'd love to get a little bit right here, just a bit, to give her a little kick on the tail of her brow, open up her supratarsal fold just a bit. So a little volume in the supraorbital. She's quite good in her infraorbital, it's mainly wrinkles, a little bit in her tear trough, and orbital malar groove, but not much. Tiny little bit in her lateral zygomatic arch for that bizygomatic dominance, but don't overdo the malar eminence, especially when she looks good and has volume. Tilt down a bit. The perioral buttress right here, not much. I'll show you the technique, but we did this, so she really doesn't need much. Tiny bit at the top. Don't go deep. That is where the nasolabial artery transverse facial is. Through that same port, I can do a little upper lip volume, and white roll Cupid's bow would be intradermal. Importantly in hers, her parasymphyseal buttress, pre-labiomental fold, and we already tightened her jowl nicely. Her chin point projection is nice. I'm not sure that will help very much, and those are the buttresses we'll inject. Let's go back up to the supraorbital. Let's start there. Access port, exactly like we're doing RF. We use a 16, 18, or the needle provided. We're going to use a 2-inch dermosculpt blunt tip cannula. I showed you it in relation to our Accutite and how small and comparable it was. And so I'm going to lift above her supraorbital. I come down to the lateral crow's foot, little pinprick. Stay away from reticular veins. Number 1 risk here is bruising. I park my little port creator, which is an angiocath. Oh, by the way, zoom in here. I want to show you something. If you were going to draw, zoom in on the tips of these 2 needles as close as you can. That is beautiful. This is like National Geographic here. If I was going to draw an arterial blood gas, an art line, put an art line in, do you think I'd be more successful with this or that? A spear, a sharp spear, or a blunt cannula? If your answer is probably a sharp spear, you probably, no one will ever prove this, have a higher embolism or angioembolic complication rate with a sharp needle, which is why I like blunt. Now, if you're aggressive with your blunt needle, you can get into any little vessel. But I intrinsically feel this is the best way. Number 1, it's faster, it's easier, there's less bruising, and probably less risk of getting in a vessel. Anyway, that's just my opinion. No one will ever prove that. Who's going to do a randomized, blinded, no pun intended study?